All right, good evening. Today is Wednesday, May 23rd, 2018. It is 5:31. I'd like to call the meeting of the Central Health Board of Managers to order. With that, we have citizens communications. We will start with citizen communications. This is the open session. First will be Yvonne Carmena from CUC. Yvonne?
You may have just signed in.
Then on citizens community.
Signed in as a citizens communication.
Oh, okay. All right, so
Okay, yeah.
so no Yvonne, no Phil. Phil? Okay. All right. Okay,
Thank you.
thank you. So Moran wants to go last, so Cynthia? Cynthia Valdez, citizen.
Hi, good evening. Cynthia Valadez, in this capacity, as I speak this moment, citizen of the world. And I just would like to say congratulations. We have two Central Health associated persons who had a successful past few months. And I would like to congratulate Cheryl Cole, and I would like to congratulate Julie Oliver, and in their capacities as candidates for their respective seats. One is state representative, and the other is congressional candidate for the Democratic Party in the November general election. And that's all I would like to say, except we're very proud of you. Thank you.
Thank you, Cynthia. Moran? Are you speaking as a citizen, Moran?
Yes.
World?
Well, good evening, everyone. As you may know, I'm
Rob, good.
sorry, I could not. Ram Saitef, a Central Health Board of Manager. I just really wanted to thank. I wish I can write thank you notes to the community, to every single person who reached out to me. I'm referring to my op-ed that was published in the Statesman. I really want to thank every single individual who reached out in terms on social media, emails, text messages, all. And really what I'm trying to be here as being the voice of the people in our community who can't be here at their table. And I'm hoping that we all can look beyond race and ethnicity in how we serve and how we deliver care. Really, I'm touched by everyone who reached out, and I thank every single person, staff, community, everyone who really touched, who really felt this op-ed resonated to them. Thank you. I'll leave it.
Thank you, Moran.
Recognize me on the agenda update.
Okay.
This time.
All right. So that's gonna go through the. If there's no objections, the agenda items will be taken in the following order: 1, 3, 7, 5, 3. I'm getting to 3 after executive session. Consent agenda: 2, 4, 8. Item 6. Item 6 will not be discussed. It is read the item. It is. What did I say? Just read it. I'll just read it. All right. 6 is discuss and take appropriate action on an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. That won't be taken today. All right. First item on the agenda is item 1, receive and discuss an update of the community health needs assessment by Travis County, the strategy for future health care delivery locations and current community care facilities. With that, I'd like to recognize Mr. Giesland.
Yes, thank you. So, members, this evening you'll first hear from Larry Wallace, and then we'll turn the microphone over to Jason Fournier and Yvonne Camarena from Community Care. The discussion that you'll hear is a continuation of the presentation that Larry started off with at the last board meeting, where we were talking about the geography of health and taking our demographic report and getting very specific about what levels of facilities we will locate in various areas around Travis County. And Larry will start with this to provide some continuity with that discussion. This is important to us because it is part of our strategy around locating service facilities in the right places for the foreseeable future. And what you'll hear too is Larry will give a brief update on some matters regarding Rosewood Zaragoza in terms of how we'll have some community outreach, but also opening up in a fair process for bringing in non-clinical services and working with our provider partners and our city and other governmental partners as well. Then Jason and his team will discuss in a very granular level the scale and scope of the clinics. And so again, it's a deeper dive beyond our own demographic report to show here's the level of services that are to be provided and some of the decisions that are forthcoming about clinic realignment and location. So I just wanted to tee this up, tie it back to our strategic plan. Larry?
Thank you. Larry Wallace, Chief Administrative Officer. Mike's already mentioned this is part 2 of what may be a 3-part conversation. And so I'm not going to take a lot of time because this is about Community Care's presentation and what they plan to do. But what I do want to say, it is, as Mike has said, a continuation of the work that we presented last month. And the whole goal is to increase access to underserved communities in Travis County. We're very fortunate to have Central Health and Community Care working in concert. Community Care is the largest provider of primary care in the city, and we're very fortunate just to have them at our side as we develop policies and strategies. We have a partner, it's a family member really, who can implement these strategies. Their board is in concert with our board, and we are one, and it's really great to have them as a partner. What you will hear tonight, and this is a continuation of what I had talked about last time, is detailed population data at a census tract level. Needs assessment, health disparities will be covered in Jason's presentation. Population density, project location, specific timelines, and his future state as he looks at his organization going forward. That's pretty much what I'll say about that. An update on the RZ project. The original plan for RZ was for it to be modified, and the Blackstock Clinic would relocate into that building. After the assessment was done, the requirements that the program directors for Blackstock, it had to be met for us to really accommodate those requests. It would be a financial obligation in excess of $4 million invested in that building. A decision was made that we would not do that, but we did not want to lose the opportunity for this location to serve the community. So as a result, there have been ultimate plans that are being developed for the building. And Jason, he'll talk about Blackstock, and some of you may have questions on what's happening with that program. In his presentation, you'll hear what that solution looks like. But our goal is to repurpose the RZ, Rosewood Zaragoza location, to the best benefit of the community. We have several partners that have expressed interest in participating. We've met with partners. There will be a meeting on June 18th, and you'll get the exact location at a later time, but it will be in the community. And our hope is that community folks will come out and really listen to the agencies that will present their services. My expectation is that they will have to really talk about the value that they bring and how they're meeting the needs. These services need to be in concert with the mission of Central Health as well as Community Care. So we think that's going to be an exciting opportunity. Ted and his team will be leading that conversation, and we'll have all the agencies present. Also at that time, we will get input from community members on any other services that they believe should be included. And once we have all of that information, we'll bring it back and we'll sit down with the partners. That'll include the City of Austin, Community Care, and others, and try to make the right decisions as far as what services would be provided there. So more to come. So I'm going to get out of the way, and that way we can have plenty of time to hear from Jason and his team around the exciting work about reprogramming community care. And some of you may not know, this community care has a history that goes back to the early 70s. So if you're talking about sites that have been located that long ago, then you know it's time to really talk about maybe what we should be doing, because everything has changed. Populations have moved, and so it's a good, timely conversation to have. Thank you.
Mr. Wallace, thank you for coming. I want to express the desire of our board to see you more often. We love seeing you. We love hearing from you. We're excited about your news every time you come, so you are welcome to come. We would love to see you more often. Thanks, Larry. Jason. Anyone, sorry, Yvonne.
So good evening, Dr. Zamora, Board of Managers, Mike and Mr. Wallace. Thank you so much for that introduction. Jason Fournier, Chief Executive Officer at Community Care Health Centers.
Hi, I'm Yvonne Camarena. I'm the Chief Operating Officer for Community Health Centers, and looking forward to our conversation tonight.
And likewise, so we have the privilege this evening of really talking to you about some of the work that we've been engaged with, both internally at Community Care, as well with our community partners, our partners here at Central Health, our partners at Community Care Collaborative, but many others, the School of Nursing, where we just came from, Dell Medical School, many, many different partners in terms of thinking and planning about what are, how, why and how can we actually strengthen access to services within the Travis community at large. And when we take a look at that, how best can we do that? And so the very first thing that we want to talk to you about this evening is really talking about our community health needs assessment. I know the larger screen's probably going to be easier to see some of the slides. This first one, I think most of you are aware, in 2015, the City of Austin demographer was charged with performing an East Austin study. And that East Austin study area really was 77 census tracts, essentially everything east of I-35, including Runberg, and minus a couple of census tracts up at the top northeast. Subsequent to that study, council member Orr Houston and others coined the term Eastern Crescent. And so when you look up at this side, this East Austin study area is really the Eastern Crescent. And so one of the things that we did differently within our community health needs assessment through this last go-around was to actually take a look at the Eastern Crescent as a focal area and really trying to look at what are the differences from an economic, social, demographic, as well as from a health outcomes perspective, and really did a deep dive into that to better understand, where populations are shifting to, what their needs may be, and really to quantify what that looks like overall for us as a community. As a federally qualified health center, Community Care Health Center, as well as Travis County, because you're a co-applicant, we fulfill that obligation for you on our side as the operator of the health center, has a requirement every 3 years to minimally perform a comprehensive needs assessment to demonstrate that we're being sensitive, responsive to ongoing needs and changing needs within our community. And that's a fairly deep dive that we're required to do with the federal government through the U.S. Department of Health and Human Services. So what you're looking up here is we replicated the 77 census tracts that are in the Eastern Crescent. So it's outlined in red on here. And so when we look at Travis County as a whole, there's 217 census tracts, of which 77 are located in the Eastern Crescent, and then another 140 that are located outside the Eastern Crescent. So for our purposes tonight, we're really just going to start talking about east of I-35 and west of I-35. And as Yvonne and I kind of move back and forth with that nomenclature, just be mindful that when we're saying east of I-35, we're also including the Runberg area in there essentially, okay? Because it did fall into that Eastern Crescent. So when we take a look at the demographic information, and one thing to look at is we used the most recent census data, which are estimates, because the last full census was done in 2010. So we used a 5-year estimate. It's referred to as the American Community Survey. So we looked at a snapshot of the 5-year estimate, which has been demonstrated to be a valid tool in making assumptions and determinations as it relates to communities at large. And so the American Community Survey from 2012 to 2016. So it's the most readily available census data. It was published in January of 2017, and then subsequent iterations of it were released in different tables. So when we look at Austin as a whole in Travis County, there's roughly 1.15 million individuals based on that information from our American Community Survey 2016. The population health estimates, or population estimates, I should say, actually pays us well over 1.2 million based on the 2017 estimates. So we continue to grow, as you very much are aware, here in Travis County and Austin, one of the fastest growing areas, metropolitan areas in the country. I think we're 12th now in the country in terms of size from a metropolitan area. When we looked at Eastern Crescent versus non-Eastern Crescent, and that's really what we did through this community health needs assessment, one of the things that we learned was that roughly 36% of the population who resides in Travis County resides in the Eastern Crescent. And then we took a look at income levels. And so when we looked at income levels, although only 36% of Travis County's residents live in the Eastern Crescent, 57% of individuals with incomes below 100% or the federal poverty level live in the Eastern Crescent. As a community health center or a federally qualified health center, our charge is really to ensure that folks who are underinsured, uninsured, and have incomes less than 200% have access to the health care they need and deserve. And so 200% for a federally qualified health center is a very important number. So we take a look at that from the census data. There's roughly 355,000 individuals that fall at 200% out of the 1.15 million that live in Travis County. Of that 355,000 individuals, 56% reside in the Eastern Crescent in terms of those that have incomes below 200%. So it doesn't take much to start realizing 36% of the population lives Eastern Crescent, yet individuals with lower income are actually, and lower resources are in the high 50s, 56, 57%. And you'll see that trend go ahead. When we look at our minority populations, roughly 60% of the over 378,000 Latinos in the area live in the Eastern Crescent, and roughly 60% of the almost 96,000 African Americans live in the Eastern Crescent. So we're seeing as well disproportionately, we're seeing our minority populations living in the Eastern Crescent. The maps on the right-hand side, on the top, demonstrate incomes below 200%. When you look at the map, the darker the color, the higher the concentration of individuals that have incomes less than 200%. And then down at the bottom, one of the interesting things is that although Travis County as a whole has roughly 27% of our population are children, 41.4% live in the Eastern Crescent as a whole. And so you're seeing a concentration of younger individuals less than 18 over in the Eastern Crescent. You're also seeing it up towards the Lake Travis area, the southwest portion of the county, but along the I-35 corridor, where our clinics have historically been, our health centers historically have been, we're seeing less children residing along that corridor. It also still has the highest population density, and we'll talk a little bit later about that. And so when we take a look at it from a health access perspective, when we look at Travis County as a whole, based on 2016 data, we have 183,833 unique individuals who are uninsured. Of that 183,883 unique individuals who are uninsured, 110,000 plus are Latino. When we look at where our uninsured population resides, recall again that 36% of Travis County population lives in the Eastern Crescent, yet 57% of our uninsured live in the Eastern Crescent. So that's, again, a stark difference between those that live in the Eastern Crescent versus those that do not. When we look at the non-Eastern Crescent, or that area west of I-35, the uninsured level drops into the low teens. And so a very stark difference between them. The proportionality of individuals who receive supplemental nutrition, the SNAP benefits as they're referred to, over 60% reside in the Eastern Crescent. And then when we take a look at free and reduced children or students who are eligible for free and reduced lunches, again, over 60% reside in the Eastern Crescent. So very telling in terms of where the population is residing and where we're seeing lower resourced individuals concentrated. So one of the things that we did is that 77 census tracts, and we've actually done a deep dive at the census tract level, and I'll come up when we talk a little bit further about the Eastern Austin area. later in the presentation. One of the things that we looked at was, okay, are there two things that we can link together to be more predictive of what would be seen as a vulnerable population? And when we at Community Care talk about vulnerable population, we're really just talking about individuals themselves aren't vulnerable, but access to resources is what makes individuals vulnerable. So when we talk about a vulnerable population, we're talking about folks who really have a lack of access to resources, which you guys very well know. And so we looked at two indicators that have been demonstrated consistently across the country to be predictive of a population that's in need. And those are looking at areas geographically that have higher levels of poverty and lower levels of high school attainment. And when you couple those two together, they can be quite predictive. And so what we looked at using a program out of the University of Missouri that was initially funded through Kaiser Permanente years ago, great program, allows us to plug in some data, it spits it out. So we plugged in 20% or greater poverty, coupled to less than 75% graduating from high school. And this is the footprint we get for Travis County. It includes 30 census tracts, to no surprise, all in the Eastern Crescent, including Runberg, but it takes that 77 census tracts down to what's defined as a vulnerable footprint. And you'll see when we overlaid this with health outcome, preventative access to preventative services, and unhealthy behaviors, that it actually is very predictive of also adverse health outcomes and predictive of health disparities that are persistent and continue to persist within our community. So you can read through the data at the bottom relative to the overall footprints. It's roughly 209,000 individuals. The makeup is heavily minority, Latino, and then we start seeing high levels of poverty, over 31% impoverished, and as well as when we start looking at linguistic isolation, 22% linguistically isolated, which means over the age of 5 and don't speak English as a prime language at home. And so this is another way for us to slice it. Kind of proving up what we've done a little bit, which of course you guys have seen through the great work that's done by our partners. We're going to refer to the critical indicators report that the Austin Public Health Department published in 2017 a little bit later. But in this, on the top left, is something that you guys sponsor. I'm not quite sure how you sponsor it, but we found this online. It's Healthy ATC, or Austin Travis County. Great website. More people need to know about it. You can go in there and have some fun playing around with the data. But when you pull that up, there's a nice link in there that looks at social needs index. And you can see the darker the color, the higher the needs. And it overlays with what we all know, which is the need is towards the east in Travis County, right? And then you take a look at the Community Advancement Network down at the bottom, and this is just pulled out of their annual report, which I think they shared with you directly a couple months here. A great map where you can see change in income levels. And the pink levels are individuals where there's been population growth between 1,500 individuals that have joined that area of our county, but adjacent counties as well. 1,500 to 2,000 new individuals that have incomes less than 200% of the federal poverty level. So these are changes within the makeup of those communities over the last 6 years through the end of 2016. So we see a trend where there's a migration of individuals and a concentration of lower income further and further eastward. We're also seeing it southward within this 6-county region. So I'm going to hand over the control to Yvonne, and she's going to walk you through our findings as it relates to health disparities and really looking at the Eastern Crescent versus that vulnerable population footprint that I just discussed, as well as compared to really populations that live west of I-35. So Yvonne, please.
Sure. So this slide actually has a lot of important information that we want to make sure that everyone is really comfortable with, and it goes back to, you have just a quick snapshot again, just for so you're aware, related to the vulnerable population footprint, along with the community care's health assessment. So just also want to make sure you'll see how this all impacts, because the conversation we really want to have is around health. And what does this information mean to us related to the populations that we serve and the potential outcomes that they have in regards to their overall health and how long they maintain a positive health outcome for the rest of their lives. So as you can see, the information tells a very compelling story. In particular, I'm going to focus on a few areas and then connect them through the remainder of the slides. The first one is if you take a look at the first area, which is all teeth lost for individuals that are greater than the age of 65. If you live in the vulnerable population or the Eastern Crescent, you're more than almost 2.5 more times likely to lose all of your teeth. And so, as you know, oral health is a major indicator of overall health and can be a predictor of other heart disease, the probability of stroke, the likelihood of developing diabetes. So if you look at that one piece, it's really important as we go through some of these other indicators. Just to also make it clear, there is one area that's green in there, and that is the one area where there is a positive piece related to cancer. We do want to be clear about that because of the population, the youth and the age of the population, that is why that is a positive indicator, because they probably are not getting to the point where they reach the age where they're forming the type of cancers that we would expect. So we just wanted to be clear on that piece of it as well. But you can also see, if you take a look at important diseases such as COPD, the chronic obstructive pulmonary disease, the importance there, chronic kidney disease. So if you look at those, you're almost 1.5 more likely to develop some of these diseases over the course of a lifetime. So we wanted to be clear. And then also, just to understand the reminder of the predictors that Jason mentioned regarding the likelihood of developing these conditions. In this piece, again, as I mentioned, just keep connecting that oral health piece because it's quite important. As you can see, the likelihood of developing diabetes is nearly 1.8 times more likely to occur, along with being diagnosed with hypertension, high blood pressure. But what was most troubling to me also was the likelihood of developing a stroke. So if you look at the probability of the conditions and the debilitation that could come along with having these types of diagnosis and the limited resources for the area, I think is really critical. And then if you also look at mental health, that's another critical area for our population, and the probability of having a mental health diagnosis is 1.6 times more likely. And again, if you start to build the case of what is the probability of chronic diseases and the likelihood of having multiple morbidities for our patients when they're more vulnerable in the areas where they reside. Another piece that we wanted to take a look at is then prevention. What does that mean? We're moving in a population health modality where we're looking at the importance of health and wellness. So if you start to look at these numbers, you see that the one that really presents itself is the probability of lack of health care, lack of insurance, and that you're almost 3 times more likely not to have access to health insurance if you live in this vulnerable area of Travis County. And what does that impact? So as you can see, again, dental visits start to show there, and the probability that you will not have access to effective dental care starts to build itself up, along with other screening, access to other screening areas.
And the best way to take a look at this, as opposed to the previous ones, is that for every individual who has a dental visit west of I-35 in the vulnerable population footprint, only 0.61 get a dental visit, 0.69 in the Eastern Crescent. That's why they're listed in red, because the preventative services and screenings are much lower on that side of Travis County than they are west of I-35. So just so that you're linking the numbers together.
Right.
So sorry, Yvonne.
No, that's perfect. So the other piece is then again continuing to evaluate access to preventative services. If you're looking at individuals and their opportunity to access services so that they have an impact for the long-term wellness of their lives, this is what we see here, is that you're less likely to have the ability to receive preventative services if you're a female, if you compare that even to your male counterparts. And the likelihood, there's a significant likelihood that you're not going to have a routine checkup with your provider. So then the other piece that we want to look at is then self-determination and how many opportunities do you actually have to impact your own health. And again, if you take a look at these numbers, they're quite compelling. You're more likely to be a smoker. if you live in the vulnerable population in the Eastern Crescent, you're more likely not to have an opportunity to have the availability of any type of exercise or time to exercise. You're more likely to be obese. And the other piece is that if you think about health, you're less likely to get the number of hours of sleep that you need. So if you're looking at the ability to make your own plans for health, you already are having trouble with meeting those reasonable opportunities for that piece. And I think if you take a look back then again at all of the conversations that we had related to health, and if you can't get dental care, if you can't get insurance, if you don't have access to routine services, what are the long-term implications to you, let alone what you may have the ability to, to provide for in your own manner. So I think then, how does this connect to community care? So I think that's the other piece that's really important in this conversation. So I want to talk real quickly about community care, just so you get a sense of who we are, the services that we're providing, the patients that we're reaching. And I think it's really important to understand the changes that have happened to us since 2009, when we have been part of the Central Health family. We started out at 55,000. We were reaching about 55 individuals annually, and you can see that we're on track to double that. And so we have a large footprint in the community, but there's a larger footprint that's needed. So we want you to see where we are at this point. So overall, as you would expect, we see more females than males. You would see that the significant number of our patients that are below the poverty limit, that's nearly 72%. You will look at our ethnicity. It is what you would expect. We are 63, almost 64% Latino, and 36% non-Latino. If you break that down just below by race, you can see that when you use the definitions by race, that there are what you expect. I think what's important is to look at our patients by insurance, and to see that we provide almost 52% of our patients are uninsured. That does include the MAP population. We have that in there as well. But you can see, though, we have about almost 23% of our patients have Medicaid, and then we are reaching some private insurances as well. So I'm going to turn it back over.
Thank you. Great job, Yvonne. I think thinking about and looking at this information, I know intuitively you as Board of Managers, highly engaged in our community and thoughtful in terms of how the resources Central Health in your charge are being used. It's extremely important. Intuitively, you know this. We, as your operator of the community health center, we know that. We see it each and every day in our patients. But when you take a look at the information and it tells a story like it is, what we're realizing and validating in terms of our own intuition is that there's significant disparity occurring within our area. And it's based on where you live and how much resource you have available to you. And that's really what this demonstrates. We were really a little bit surprised as it relates to the vulnerable footprint, having known that that's been used to identify populations. We're not aware of anyone that's taken the behavioral risk factor surveillance survey information and overlaid it with the vulnerable population footprint. And to see in every one of those for the vulnerable population to be worse even than the Eastern Crescent comparative to the rest of the county was something that we weren't expecting. For it to be that much of a difference between. The good news is, and what we didn't put on this, but what I want to make sure that you leave with, well, when you look at this relative to our neighbors and our community members who happen to live in either the vulnerable population footprint or happen to live in the Eastern Crescent, what you're not seeing is that we're faring as a county much better than the state of Texas. And if we looked at large geographic areas like Dallas, Houston, San Antonio, and we use the same metrics and we overlaid that, we'd have to try to replicate vulnerable populations there as well, which would take a little bit. But at the state level and in the large metropolitan areas, we are faring better than our peers because of the presence of Central Health and the taxing authority here. And so while it tells a story relative to what's going on in our community, you also have to look beyond our geographic borders to realize that as a county and as a collective group of providers and interested parties, we're doing better than our peers across the state. So we want to concentrate on our area, but also take solace and really want to compliment you on the great work to get us to this point. So as we think moving forward, you know, there's multiple needs that we have within the community. And at Community Care, what we're trying to do is to ensure that we're data informed. And that's what you've seen. We've got this obligation to the feds, but it's just not going through the motions. It's really using the data that's available to us to make the best decisions. And then we couple that with the great data that's being produced here at Central Health in terms of looking 5 years out and where are those areas where we think there's going to be additional needs. And I know JP and Mr. Wallace and others have presented to you on that, and you've seen that information. And so really trying to look at this, because to a certain degree, while we can use data, we also have to use that data and inform it then with our partners. We also have to inform it with our community members. We have to listen and talk with our community members in the populations. What's unique about a federally qualified health center that you're probably also aware of is that we have to be community directed. And so on Community Care's board, we actually have patients who use our services that are residing in the community, and they have a voice in terms of where their services should be, how comprehensive those services should be. And that's really, as your co-applicant, that's their charge. That's what the federal government expects of them to do. That's their responsibility. And so we want to use each aspect and not treat them in silo to arrive at the best way for us to deliver care within the community. So the other part is that the services that we provide need to be directed towards underserved populations, uninsured, underinsured individuals, and lower income individuals. So moving forward, what are our goals? Well, we want to go ahead and make sure that we're geographically sensitive to where people need. And I think the city of Austin, Travis County at large, should highly be commended for the activities it's had over the years under Board of Manager Shannon Jones' leadership at Austin Public Health, but others, but just taking a look at the fact that there was a robust system of care that was developed, and it was aligned with where historically the populations have lived. Those populations, as we very well know, are transitioning. And so we now need to be more geographically sensitive. And how do we do that? Through Community Care with our assets, with Central Health, with your assets and our partners. We also want to be culturally aware. We don't talk about one community, we talk about communities. And we talk about neighborhoods. And how do we leverage our very limited resources? Because we cannot be everything to everyone. So we have to be very deliberate about how we use our resources. Because at the end of the day, there has to be a financial model that allows this to be sustained. And so we have to be very deliberate and thoughtful and tactful as it relates to that. So we have to look at long-term sustainability. We also want to look at, one of our goals is not only to treat the individual, but to look at it from a population perspective, both in the short term from an outcomes perspective and long term. And so not just the four walls of where people get their care, but how do we use our care coordination, our nurses, who all under Yvonne's great leadership and others in our organization are really working every day to connect people not only with the services they need that day, but the preventative services they need in 3 months, and really trying to increase our capacity and systems to do that. Being cost effective, of course, we need to be good stewards of not only the resources that Central Health and Community Care Collaborative provides to us, but we get a grant through the federal government of almost $6 million to support the services, so we have to be good stewards there. The other, which is a little bit more unique of a tact for us in a large geographic area like this, we also want to challenge ourselves to say that around each one of our clinics, we've got a target population we're trying to reach. And that target population, for example, in Del Valle, could be individuals that reside in 78617, 78619, and while we'll still allow anyone within our community to come to one of our clinics, who we're really trying to get to by site is going to be more defined so that we have a better idea at the neighborhood, local level in terms of what our impact is. Right now we have patients coming across the entire Travis County area. We'll have folks who are coming far west to far east, north, south, wherever they can be seen. And a lot of that has to do with the fact that we have 356,000 individuals that are below 200% and roughly 184,000 individuals who are uninsured. So the slide that you have up in front of you is really where we are today. And what you can see on this is really our sites across Travis County. And it doesn't take much to realize that we're still aligned mostly along the I-35 corridor with a couple of exceptions, right? Our Manor site, our new Del Valle site, which opened thanks to the support of Travis County Commissioners in their facility last fall, and then our Southeast Health and Wellness, and then our William Cannon Convenient Care Walk-in Clinic further south. but almost all the other sites are aligned along the I-35 corridor. And so when we take a look at this, then how do we approach this moving forward? On this, and tie-barring back to Mr. Wallace's presentation, is the small blue pins are smaller sites. They're the level 3 facilities that he talked to you about. So they're 1 to 2 provider sites. The larger green pins are 3 to 7 provider sites, and then the very large orange pins are the 8+ provider sites. Right now, we only have 2 large facilities, Southeast Health and Wellness and our North Central site. And then coupled to that is, as you'll see, there's green stars on here. Those are our walk-in clinics. That's Hancock and our William Cannon, where folks don't need to have an appointment. They come in, they basically get in line, and they're being seen as we're able to see them on a daily basis till 8 p.m. at night. This very small purple stars, which are tough to see, those are where we actually have a provider deployed where it's an integral care site, and we have one provider who goes there a couple times, and so we have 3 sites where we do that. And then we have our homeless program, which isn't as easy to drop onto. And so I want to take a pause and kind of come back to talk about a local level here, because East Austin, and I've been in the community almost a year, but it doesn't take much for all of us to recognize that there's a lot of rapid change occurring. We all see condos going up. It feels like every time I drive in this zip code here, 78702, there's something new going up. A lot of exciting things for those that are moving in, less exciting for those that are being displaced, right? And so when we take a look at the community as a whole, we've had historically 3 health centers of late in this area. We have 2 operating right now, and coupled to that is Seton's McCarthy Clinic, which is down on the bottom right side near the river. And so what we did is a deeper dive. I'm not going to walk through each one of these boxes, but what we did is we looked at the census tract level and we looked at the population. What's more important is really kind of teeing this up. For us as a community health center, we have to look at how best do we deploy our resources. And so when we review the east side of Austin, it becomes very apparent to us that long-term we do not need to have 3 health centers, let alone perhaps 2 health centers. And it was one of the reasons when we met with our board last fall and we were contemplating, should we move the family medicine residency program, Blackstock, over to Rosewood, Zaragoza. We did a deep dive into data, and recall that this is data that's 2 years, 18 months to 2 years old, right? And we know things continue to change. And when we take a look at that, it became very apparent that there are less kiddos in the area. Family medicine residency program needs to have pediatrics as part of their patient panel. And there were already concerns as related to the patient panel occurring within the existing Blackstock site, and we were struggling with that. And so we looked at the assets that Central Health has provided to us through Southeast Health and Wellness, where that large clinic is, and we determined that we had capacity to move the residency program in. And oh, by the way, that zip code, 78741, has a high underserved population, 32,000 plus individuals below 200% of the federal poverty level, of which about 16,000 are uninsured. That's a large number. For all of East Austin, uninsured, 5,200, right? That's the current, and that includes half of 21.11 census tract, which really is not East Austin, and most of those folks will probably go down to Southeast Health and Wellness because it's close to Airport Road and they can get quicker down to Southeast Health and Wellness than they could to one of our health centers. So when we take a look at what the need is in East Austin, at 100% need, if we were to meet the need of every individual who we consider to be underserved, so 200% or Medicaid plus uninsured, it's about 10 to 12,000 individuals. There isn't a clinic system in the country that gets to 100% of anyone, right? That just doesn't happen. So if you looked at 50%, the number then falls to 5,000 to 6,000 individuals. One of our providers can care for 1,100 individuals to 1,200 individuals each year. That's not seeing them just once. That's on average seeing them 3+ times. And so when we look at what's realistic in East Austin for us and needs long term, we're probably looking at a 6, 7, 8 provider site. And so when we look at how we change and reallocate resources, this has to be part of our equation. It's really one of the fundamental reasons why we decided not to bring Blackstock back over to the east side into Rosewood, Zaragoza. And as we see the community continue to change and our patient populations that we've historically served move further east within the community at large in Travis County, we have to think about how best do we position our services so that they don't have to drive in miles and miles. Actually, When both Mike and I were newbies last summer, he joined me down at East Austin when I was getting to know our East Austin Health Center, to know our staff down there. I asked a question about, okay, on an eligibility front, how many individuals from 78702, and it's on Kamal, it's just right up the street from here, how many individuals are from this zip code? And the answer from the eligibility individual last summer was 1 out of 20, maybe, right? So that really was an eye-opener. I think I was about 8 weeks into being in this beautiful community of ours. So this slide, I'm not going to spend too much time other than that this is population density. So you look at where populations are concentrated within Travis County as of 2016. To no surprise, it's still along the I-35 corridor, okay? And so when you move further out into the outer regions of Travis County, there's less population density. The reason why I bring this in is as we start looking at physical assets with our partners at Central Health, on the operator side, we're always thinking about, okay, can we actually go ahead and put a provider or several providers into a site and make a go of it, frankly, right? We have to have a financial sustained model because at the end of the day, community care is standing on its own financially, and so we have to prove out to our board what our financial model is so that we can demonstrate that it'll go ahead and be sustainable, not only short-term, but longer-term for us as we're looking at it. And also making sure that we're sensitive to the patient needs. So this is a very high-arching overview timeline in terms of the next 5 years from our perspective. I'm going to qualify this by saying this is certainly going to change. What won't change as much is what's in green, because these are very far along initiatives that we have. And so in the very near term, we're going to be adding multiple women's health services clinics to our network, actually in early June. You'll see and probably see a press release going out tomorrow. But 3 here in Travis County are being added in early June, and so we're very pleased with that. Aligns very well with our mission, and we're very pleased that we were able to work with a community provider that was committed to this population for years to ensure that they're being sustained. But we've got other things, our Blackstock operations consolidating hopefully later this year down into our Southeast Health and Wellness. Additional to that is we have a request with the federal government to repurpose about $733,000 to renovate Southeast Health and Wellness. In the back corner of the conference room, our colleagues, Mr. Wallace, Mr. Gieselin, others have been very supportive about trying to increase convenient care access. So one of the ways that we're going to do that is to establish walk-in care at Southeast Health and Wellness. We met with the Community Advisory Committee. They were extremely excited. They wanted to see that from day one at that site. So we're pleased to do that. One of the things that may happen as a result of that, and we feel pretty strongly about this, is that as we look further south, we need more of a primary care. So I think if you stay in the community long enough, we flip back to what we've done before too. And so William Cannon at one point was primary care, then we put it to walk-in. We're going to flip it back to primary care. As we think about a longer term strategy, because Dove Springs needs to have a larger clinical footprint longer term, but we're not quite there. So you see that off closer to 2022. And so we're trying to be very thoughtful with the resources that you place in our charge through Central Health, as well as our own assets as a whole. We feel very confident that the new facility in Del Valle is going to move forward through Travis County, but that planning will happen later this year with that Board of Commissioners, the Commissioners Court, and then some of the other things that we're thinking about as well. One of the ones that I'll hit on, because it may come up in the questions, is we're looking to repurpose a part of Rosewood Zaragoza as we look at transitioning convenient care to Southeast and going primary care. One of the things that we collectively as leaders at community care, we struggle with walking convenient care. And so we think that at least in the near term, repurposing one of the hallways at Rosewood Zaragoza would be a good service to the community, would also allow us to meet needs. By way of example, William Cannon and Hancock, usually their capacity is filled by 4:30 every day. And we're intending to try to be there till 8. But there's so many folks trying to be seen on the same day that we have to go ahead and close at that time. So looking future state, everything in yellow is either a new clinic. So you can see roughly where the women's health clinics are. They have WH, but they also have a nice little pink women's logo or emblem or picture or symbol, whatever it is. It's a symbol. I should have landed there first, right? And then you can see that some of the other changes that we're contemplating are Del Valle, which I've talked about, Southeast, William Cannon, but Community First Village. We have a very small clinic that we operate there with integral care, one provider a couple times a week. We see a larger footprint there longer term as Mobile O's and Fishes, under Alan Graham's leadership, looks to expand its footprint to care for and house chronically homeless individuals to the level of 1,000 plus individuals. We want to be a partner with that, and not only serve those individuals, but community members at large. So we're seeing that as a level 2 facility, and it'll be dependent. There's ongoing conversations. Probably what's most notable and what we're most excited at, when we take a look at our overall larger centers, we're excited about the Northeast Health Center in Colony Park. When we take a look, 35% of the residents in the Colony Park area in that census tract are children. It's a high level. So the kids we used to serve in East Austin, some of them are out that way. And so it makes sense for us to look at prenatal services out there, pediatric services, and really looking at family medicine comprehensively. So that's one of the ones that we're working with Central Health and the city and many others about looking at that site as a possibility moving forward. Not only just us, but with integral care, with the city of Austin, hopefully relative to the programs that they have, and a really comprehensive site, because that works very well for our staff. And then you'll see on here is that part of what we're looking at is that when we get into less densely populated areas, we feel strongly that we need to have access to mobility. In the short term, that could be accomplished through a mobile unit. And so having done this before, we've talked with our board, we talked with them last fall and with Central Health. We're excited about what that possibility looked like. We're not there quite yet in terms of making this realized, but we think that's a strategy to bring services to folks, at least in the short term. That's a highly effective way. Think about it this way, the Dove Valley site that we have right now has 2 exam rooms in it. Think about a large RV or a Greyhound bus that's converted. You can get 2 exam rooms in there, come to the same spot and really provide some comprehensive care. And it works very effectively within rural areas as well. So coming to, I don't know if it was formally within the Board of Managers meeting last time or if it was afterwards, Board of Manager Jones asked that we go ahead and overlay mortality as produced through the critical indicators report through the city of Austin. So what we did is we pulled out the highest age-adjusted cause of all causes of mortality. So what's in dark blue here? This is the area in Travis County that has the highest level of mortality within our county. And you can see where our existing sites are and the ones in yellow. So Northeast drops it right in the heart of that top part over at the top. And transportation, of course, is going to be part of our solution moving forward, as well as electronic health systems. The next one is really highest average age at death. And this comes back to one of the other reasons why when you look at cancer being lower in this area, comparative to west of I-35, not only is it the kiddos, and there's more kids in the Eastern Crescent, the other thing you have to link is the fact that if on average you have individuals dying by the age of 63.3 in these areas, they don't live long enough to grow cancer, guys. The vast majority of cancers happen after the age of 60, right? Now, and I don't, for people who suffer from cancer and afflicted at a younger age than that, absolutely. My mother passed away from lung cancer at a much younger age than that, so very sensitive to that. But when you take a look at this, this is demonstrating where folks are passing away younger than anywhere else in the county and where our clinics will be moving forward. So you see a significant need in Dell Valley, Austin's Colony, Hornsby Bend, Colony Park, and still shooting down in the 78744, 78741, Montopolis area and down into Dove Springs. Absolutely. So you see that disparity. So I know we're going to get some questions, so I put this slide up here. Our mission was changed last fall with our board of directors, and so you can see that. The other thing is that we changed our vision, and really as an organization, we're really striving to get health equity for all within our community, and we have 3 strides for that. We feel it's important not only to treat people from an equal perspective, but equity for those that are that know this, and all of you know this, is really about meeting people where they are and making sure that they have the resources they need to thrive. And that's really what we're trying to accomplish with our strategy, with our partners here at Central Health, and so many other partners in the community at large. So happy to answer any questions you may have.
Jason, Yvonne, thank you. That was an incredible presentation, and we need to move on to what you're discussing here about the Eastern Crescent. With that, I'm going to recognize Board Member Jones.
Yeah, I echo the chair. That was an excellent presentation. It was very comprehensive and very thorough, and I compliment you on doing it. My almost 20 years here, I've not seen anyone who's taken that type of perspective. So thank you so very much for that.
More than happy
A
to.
couple of questions and comments. One is, can you help, when you talk about the vulnerable areas, that definition of vulnerable, I heard you talk about income, and I think you said poverty.
High school
High
educational.
school education. I didn't hear anything about age.
There was not. So the measure is really two things linked together. Greater than 20% of poverty, less than 75% of adults that are 25 or older graduating for high school. You take those two, they're predictive. You could overlay age as well, but those are two that have been used just as a quick way to identify populations that most likely have needs.
So is that saying that those who are elderly do not?
No, not at all, not at all.
Okay,
It's just a quick way for us to identify a population. So if we looked at older individuals and really overlaid it in our analyses to determine, do we have pockets of older individuals who have needs? Certainly we would. And we expect that actually when we look at the east side of Austin, we think that one of the populations that has historically been served through one of our health centers or through one of our partners that's going to persist is an older population because they're more likely to stay in the area. And then when we take a look at the Housing Authority developments here in East Austin, they have a preference for individuals who are 62 plus years of age and who are disabled. So we think, yeah, there's certainly going to be areas like that hotspot.
okay, and particularly in the Eastern Crescent, you're going to find a lot of those, not only within 183, but also outside of 183 as gentrification continues to manifest itself. Second quick question is, so in terms of your location of your center, 78702 zip code particularly, you alluded to currently you have a plethora of centers there, and the question is, with the changing demographics, changing vulnerability of that population, the need to continue to have that many facilities. And so can you speak a little bit about what your strategy was or is to do that long term?
Yeah, I think we're going to need to right size the number of health centers we have on the east side. As I mentioned earlier when I was showing the East Austin map, we think that probably longer term, we need one large health center in East Austin. And so we're going to need to work with our community partners and other partners to determine what that site looks like and what other resources might we need. We might be able to flip one of the sites to do geriatric services longer term. We're not there yet, but I think that's a possibility. We also have a high specialty need across our system. And so one of the considerations would be is as we look at the physical assets that we have, being along I-35 and the I-35 corridor for specialty care wouldn't be a bad thing, because fortunately when you need specialty care, it isn't continuous. And so you can do a hit and then be seen back at your primary care medical home. So those are some of the things as we work with our partners at Central Health and other community members about ways for us to think about how we might repurpose the assets that are available to us. But I think long term, we see really one large health center being needed 2-3 years out here in East Austin, especially as we're needing to take some of the resources that are here, our staff, providers, our nurses, all those folks, and use them where our patients are moving to and will be.
Thanks very much.
Yeah, no, more than happy to.
Ron?
Oh, thank you. Thank you, Jason. Maybe you need a cup of water.
My staff knows I can talk.
Glad to have water.
No, right? Not at all.
So, but thank you so much. This is really helpful and very dense. Few points. You touched on my sweet spot, children. And thinking of the life course perspective and how what the lifestyle of a child that impact it will carry on into adulthood. Your community, so you identified 41.4 of Travis County are children.
In the Eastern Crescent, yes.
Eastern Crescent, who are also part of the population that we are serving. Now, another thing that we also, in defining vulnerability, education is part of it. So, is there a way that that you can also collect their academic performance, where they are, and so you can intervene at an early age with these children?
we can't, intermediate school districts
Districts can.
can. One of the ways you can do that is if you have school-based clinics. And I've seen that in other parts of the country, but only at those sites, and you're subject to what's known as FERPA. And don't ask me to define what FERPA is, but it's the federal education, and the lawyers can answer the rest. But it really precludes schools from sharing educational records with other parties. It's kind of like HIPAA for schools. And so, but there have been pilot projects, and with our ISDs, you can demonstrate if they're willing to look at an intervention within the school setting, to go ahead. And I believe Integral Care is doing and will be coming out, I heard at the panel discussion last week, in terms of the schools that they've been placed in, that they have a forthcoming report that will demonstrate the impact of their embedded behavioral health therapists within the schools.
Okay, and also you have here, you broke down obesity by 18 plus. Can you also break it down with children?
So that one's a little bit more difficult. So the Behavioral Risk Factor Surveillance Survey, as you may know, is directed towards adults. And so we can use Youth Behavioral Risk Factor Surveillance Survey. It's not as readily available. Some of the census tract data has only become recently available in 2016, and it came through the 500 Cities Initiative, which was Centers for Disease Control and Robert Wood Johnson Foundation. I've yet to see something local at the census tract level for the youth. But if anyone knows that, we'd be happy to take a look at that.
Okay.
Great point.
Another thing, so in 2018, you're projected to serve about 100,000 individuals. And we have over 300 plus. So there's a lot of unmet needs within our community. And how do you think the best way to tackle and address to really close these gaps and really to close all these disparities with our population? So what's the solution in your mind?
Well, it's going to be multi-tiered and multifold. That is the loaded question, right? That's the so important question. And so I think part of it is looking at where our services are, how comprehensive are the services. There's the brick and mortar strategy clinics, and then there's taking a look at how can we use technology differently for patient engagement activation. Also taking a look at strategies through which, not just through telemedicine, but care coordination strategies, and then really looking at population health strategies for our patients. So if I take a look at, and it's going to take all of us, the saying takes a village, it's very true. And so our partners, Albuin, Lone Star, Peoples, ourselves, Seton, St. David's, all of us working collaboratively and cooperatively, School of Nursing, others who are interested in this space, really working to try to get as broad a spectrum of care. When we take a look at it, the individuals, when we have 184,000 uninsured individuals each year and 356,000 less than 200%, not everyone's going to need care that year, right? Some individuals are going to be well where they don't need ongoing care. And so how do we actually target and right-size the system as a whole? And we feel strongly that part of it's the model that we're developing at community care as it relates to our expanded care teams, really taking a look at how best do we support and engage our patients. And then also, when they're outside our four walls, how do we reach out to them to remind them of what they need to be doing and also be available to them at the same time? So it's a very complex web that needs to be woven to get to it. I'm hopeful that we'll get there, but I don't think that we're going to get to 100% of folks being able to access care right now or in the near term, their care needs in a primary care setting.
One last question.
Of course.
You said you're expanding women's clinic.
Yes.
And what services are you going to be providing there? And would you have mammogram?
So, I'll touch on the first part of your question, Maram. These are very small clinical footprints. They're mostly one provider sites in terms of the examiner. But the services we'll provide are comprehensive women's health services, including reproductive health services, contraceptive care, as well as prenatal services and gynecological care. So it's the full spectrum of women's health services. If a woman has a primary care need that the obstetrician, gynecologist, or the advanced practice provider is not able to meet, we'll coordinate care with one of our other sites to ensure that their care needs are being met. As it relates to mammography, those sites will not have mammography, but we have capacity at our Southeast Health and Wellness and North Central for mammography. And so again, because those are services that are needed a little less frequently. We can help folks in terms of transportation to Southeast or North Central. We're actively recruiting for a radiological technician for our Southeast. There's just, one of the things I've learned recently is there's a deficit of rad techs in Central Texas. So if you know one, send them our way, please.
Well, thank you.
Yeah, no, more than happy.
Interest of time, I'm going to, hopefully, everybody will be brief, because we're going to lose 2 board members, and I'd like to be able to get to these next 3 agenda items before they leave.
Just quickly, and I did ask you this, whether or not it would be possible to do the overlay with the breakdown by ethnicity.
More than happy to provide that to
I
you.
think that would be very important to have, especially with respect to the children and to the adults, and maybe even to the geriatric component, so that appropriate strategies, culturally and linguistically appropriate strategies could be developed. And we'll be back to hear from you so that we can ask you more questions. Is that true, Dr. Samora?
We'll bring Jason back, we'll keep on back, yes.
Okay, and then with respect to the presentation at RZ, are we going to come back and revisit that so I don't have to ask anything right now?
Yes, and so after Mr. Wallace alluded to, we meet with the community and open up the process to see who all the necessary non-clinicals as well as what the clinical footprint will be. The board will have additional information on that and the opportunity to discuss it.
And that was a concern of mine, because when we did the way we did being on that advisory committee for the Southeast Health and Wellness Center development, and Larry knows this full well, we worked on what we wanted to see there in the interest of our communities and the needs. Then we talked about what kinds of resources outside medical would be good and appropriate for that site, but that was after we looked at everything that we needed to serve the health needs of our community, because we were looking at what we were required to do by statute. The secondary was, what are the resources that are going to be available out there, because that is an area that was going to be targeted to receive clients from where there are no resources, and that's Southeast Travis County. Within this area here, 78702, which is my zip code, and I live down the street at Rosewood, Zaragoza, which would have been the clinic that I go to, the City of Austin building side, which has a lot of resources. And I would think that it would be a good idea for us to, if we're efficiency of dollars, that if there were things that we needed to build up on the City of Austin side, which is the left side building, that's where we could do that. Let's see how we can work with our partners there. And on the right side, let's look at providing the needs for our community and how we can. And with respect to, just one last thing, we knew we didn't need Sandra Joy Anderson, but we did if we were going to use it to tie what we thought was going to be original use, and that was to behavioral and mental health concerns. There was a big to-do about bringing in Dr. Lawson, and we were going to have a component at HT, and we were going to be working with the behavioral and mental health needs of our communities, especially of our poverty and targeted population communities. And so I think that that would be a very good site. We can go back and do exactly what we said we were going to do, and then the other, the Rosewood Zaragoza can remain as it was before, and that was the community clinic for our population in need. So, and I just want to thank you for having done this, and thank all of y'all who participated in the development of this. Thank you.
We'll have more time to discuss. Dr. Hagan.
Yes, really quickly, Jason, thank you so much for showing us how you data that we have and that you've gathered to inform our service delivery. Looking at I call this the BRFS, BRFS.
Yeah, that's what we call it too.
Which is weird, right? Yeah. But looking at your relative risks there, I am with you in that I thought a lot of those would actually be higher, which perhaps speaks to the service delivery that we have already managed to do. A couple of things that I think would be really helpful in strengthening these results, just to show them to people and to us. Yeah. One is it would be really good to get a sense of the population size for each of those tracks. I might look at these diagrams and go, oh, 1.2 doesn't sound like a very big relative risk, but when you compound that over thousands of people, it obviously makes a much bigger impact. So I'd love to see that.
Great suggestion. Yeah. We'll revise them and get them to you to Mike and he'll distribute.
That'd be really cool to see that. And the second thing would be, when you look at a relative risk, of course, you also want to know something about the incidence of what we're looking at in the population. Because, like, the example I always have in my head is contraceptive pill use, right? We talk about, oh, you've got double the risk of a blood clot, and then you look at the absolute risk of a blood clot in the population, and it's tiny. So the relative risk really doesn't mean that much. Whereas here, I think we're talking about things that are fairly common. And so if you had some way of giving us a sense for how common these things are, I think that would also really strengthen the impact of these graphs. But I really thank you for them. I'm just in heaven.
Yeah, and we'll send over the backup spreadsheet that has each one of the percentages
That'd be super
by,
cool.
by the region rolled up, because it's drilled in at the individual census tract level, and that's how we rolled it up to get to this. So.
Got it.
And these are crude prevalence rates, just so
Yeah,
that
no,
you're
totally.
aware.
I appreciate
They're not age adjusted, so they're as good as you can get, but they're not everything they should be.
Professor Greenberg.
Yeah, I just want to say thank you as another Data Geek. Keep it coming, and we appreciate your effort and Mr. Wallace and Mr. Giesland and all the many other people who we can't call out by name on all the staffs who are helping you. I'll study this and we'll come back to you with strategic planning. Thank you.
Thank you.
Karina, Julie, any questions? Well, I'm going to follow my own advice and be brief. Again, I want to thank both of you. But I'm going to tell you a little funny story. You know, Yvonne and I went out to the newest clinic, which is that elementary school that is escaping my name.
Overton?
Overton, there you go. Went out there to meet with the Univision reporter, and we talked about why we were doing this and why we were moving a community care clinic to that area. And it just enlightened her. And you could see little just her brain just, boop, when we talked about the numbers that you just gave us here. And so, you know, time goes by. I think the news media didn't show it until 2 weeks later. You know, so I had forgotten what I had done. So my staff starts coming to me and says, "Why are we moving to Northeast Center?" We had 2 phone calls. One, that they were happy that I was going to be moving out to the Northeast Center.
We have a job for you,
Or why
Dr.
was I leaving East Austin?
Moving to Colony
Going,
Park, Dr.
"What?"
Z.
And I said, "Oh, the Univision." So the citizens are listening. Great. And that was great. It was great that Yvonne.
Patients are listening even.
Well, I mean,
closer.
they're the consumers. We share patients.
Yes.
You know, your patients are my patients, and my patients are your patients. And so it was very good that Yvonne got Univision to come out there, because it didn't seem like they were really interested until we started giving them those numbers that you just showed us. This is where they're at. This is where we need to be. It's the right thing to do. Be here, serve them, so they don't have to go so far. Mom and Dad may be working, and they may just have that one vehicle, but they can walk here, or take a bus here, or take a taxi here. They're listening. They're consumers. So we need to do that. I don't know, Yvonne's not here. I saw a minute ago, but I guess he left. And Ted, you're here. So we need to do more of these things. We need to tell them, what are we doing? Where are we moving to? Where are we expanding our services to help you, to be there for you? And you guys are doing an amazing job.
Well, thank you for that, and thanks for communicating the needs within the community. It's so important for us all to be doing that.
My patients were a little scared that I was leaving, but I told them, we reassured them that I was still staying, that we're going to be supportive of community care clinics. Thank you. Thank you again.
Thank you for the opportunity, everyone.
All right, let's.
Good job. Well done.
Well done. We're going to take the next three agenda items together, so I'm going to go ahead and announce them. Item number 3 is discuss and take appropriate action on the following items related to Central Health's president and CEO. A, formal approval of president and CEO's annual performance evaluation. B, timeline for adoption for the annual performance evaluation tool to be used in 2019. And C, renewal and amendment to current employment contracts, including changes to compensation package and benefits. Item 7, discuss and take appropriate action on Central Health's owned property, including the downtown campus and adjacent properties. And 5, agenda item 5, discuss and take appropriate action on 1115 Medicaid waiver, delivery system reform, incentive payment, district projects, the community care collaborative, including healthcare delivery arrangements and other interrelated community partnerships. With that, it is, what time is it? 6:45. I announce the Board is convening to an executive session to discuss agenda items 3, 5, and 7 under section 551.071 of the Texas Government Code, consultation with attorney. And item 3, under section 551.074 of the Texas Government Code, personal matters. Item 5, under section 551.085 of the Texas Government Code, deliberation of the governing board of certain providers of healthcare services. And item 7, under section 551.072 of the Texas Government Code, deliberation regarding real property. With that, let's take 5 minutes and get some food, so we're not starving. So, thank you, Nicole. Ready? All right. We're going to be back in open session. It is like 7:27. The board will reconvene in open session. No action will be taken on items 5 or 7. We're going to reread item 3, which is discuss and take appropriate action on the following items related to Central Health President and CEO. A, formal approval of President and CEO's annual performance evaluation. B, timeline for adoption for the annual performance evaluation tool to be used in 2019. C, renewal and amendment to current employment contract, including changes to compensation package and benefits. And with that, Ms. Willers?
All right. Susan Willers, Vice President of Human Resources. And I've given you all the documents. Holly, they're just going to take action at this point? Okay.
So with that, I'll entertain a motion to, on item 3. What's that?
Make a motion if you want.
Please.
Move that the board approve the president and CEO's formal performance evaluation for the period of May 15, 2017 to May 15, 2018, which evaluation recognizes that Mr. Gieslin's performance over the past 12 months has exceeded the board's performance expectations. I also move that the board express its appreciation to Mr. Gieslin for his continued dedication to Central Health's mission and vision, his efforts to enhance community engagement, and his commitment to promoting a strong organizational culture and fiscal responsibility. I further move that the board renew the employment agreement between Central Health and Mike Gieslin for the first optional renewal period beginning on June 1st, 2018 and ending on May 31st, 2019. Finally, I move that the board approve the following amendments to the aforementioned employment agreement. An amendment to increase the president and CEO's base salary by 5%, which would increase his base pay from $305,000 to $320,250. An amendment to replace the current renewal term provision with an automatic renewal term provision. An amendment to address the purchase of short and long-term disability plans for the president and CEO. And finally, an amendment to the date on which subsequent formal performance reviews will be conducted.
Do I hear a second? So we have a motion by Board Member Daniel and seconded by Board Member Valdez. Any discussion? Okay, no discussion. All in favor, say aye.
Aye.
Was there a discussion? Did you have a discussion?
I just want to make one public comment if I could. I just want to thank Mike Gieslin for what I think is a very successful first year here. We've, I think the community probably recognizes a strong interest in engagement, communications on a more regular and robust basis. And in my view, that's going a long way, I think, to helping improve the trust and relationship that we have with the community. I think we've had a longstanding practice of providing high-quality health care and expanding services, and Mike is helping the organization tell that story in a better and more effective way, and to engage the population that we serve and the taxpayers beyond what we've done in the past. So thank you very much.
Honor's mine. Thank you.
Well, Manager Daniels
I
literally
was
read my
reading your mind.
I want to echo everything that she has said, and thank you, Mike, for your leadership and moving us further along and strengthening our relationships and really putting our patients first and foremost. Thank you.
Ditto from the rest of the board.
We all concur. Exactly.
Yeah, I just want to say, Mike, I concur with what everyone says. I've been here only for this evaluation period, roughly about 2.5, 3 months at the most. So I will be abstaining. I want you to know it's not a reflection on my view of your performance. It's just as a professional, I don't feel that I've been here long enough to do a complete evaluation for that.
Understood.
Thank you, Board Member. Yes, Mr. Gieslin.
So if there's no other comments by the board members, I want to thank you all for this process. I thought it was very fair, and but also I really do appreciate the kind words, but also the feedback too, in terms of things that we can be doing different. And I think that's how these types of partnerships are supposed to work with CEOs and boards. It is not just a one-man or one-woman show where you just head off. You really need to work collaboratively together, and to know where the course corrections are or where the fine-tuning is needed is absolutely necessary. And I cannot thank you all enough for that feedback, and I do appreciate it. Thank you.
Thank you.
Thank you, Ms. Elam. All right, all in favor say aye.
Aye.
All against say no. And Board Member Jones will abstain. All right? Yeah, one abstention. With that, the motion carries, and thank you, Mr. Giesland.
Thank you, members.
Thank you.
Professor, thank you. Professor, I know you need to leave as well. Okay, all right. All right, now we're going to move on to the consent agenda. C1, approve minutes for the following meeting of the Central Health Board of Managers, April 25th, 2018, and May 11th, 2018. Can I put those all and read it one time, and then no one's going to, is anyone pulling anything?
No.
All right. C2, receive a report of the April 2018 financial statements for Central Health as presented to the Budget and Finance Committee. C3, receive a report of the 2018 financial statements for the Community Care Clinic Collaborative as presented to the Budget and Finance Committee. C4, receive the April 2018 investment report and ratify Central Health investments for 2018. C5, approve an intra-local agreement between Central Health and the Public Employee Benefits Alliance for membership in an employee benefit purchasing cooperative as recommended by the Budget and Finance Committee. C6, approve amendments to the agreement between Community Care Collaborative and Community Care Clinic for primary care services as recommended by the Budget and Finance Committee. A, amendments for expanded dermatology services, and B, amendment for the community health worker services. C7, approve the establishment of a vendor pool for architectural engineering services in the amount not to exceed $150,000 to be allocated as appropriate among the selected firms, and authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to and more favorable than those presented with BSA Life Structures, Inc., O'Connell, Robertson, and Page Sutherland, as recommended by the Budget and Finance Committee. Approve the establishment of a vendor pool for civil engineering services in an amount not to exceed $25,000 to be allocated as appropriate among selected firms, and authorize Central Health President and CEO to negotiate and enter in agreements on terms similar to or more favorable than those presented with Dowsett, Dowsett Chan, Jose Aguerrero, MWM Design, and UDF. Approve the establishment of a vendor pool for land serving services in an amount not to exceed $100,000 to be allocated as appropriate among the selected firms, and authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to or more favorable than those presented with McKim and Creed, MWM Design, Sherwood and Stantic, as recommended by the Budget and Finance Committee. Let's go back. So, do I hear a motion?
Lawyer should do that.
Yeah. Can I hear a motion?
So move. I move that we adopt the Central Health Board of Managers consent agenda items C1 through C7.
Second? Professor Aiken, seconded. We have a motion by Valdez, Board Member Valdez, and seconded by Professor Aiken. All in favor, say aye.
Aye.
All against, say no. I forgot, I need to abstain from this one because I do know one of the contractors, so I'm going to abstain from this vote. Is that okay?
Right, but are there any other abstentions?
Any other abstentions? No, we're not abstaining. Okay. All right. Motion passes. Thank you. All right. Agenda item 2, receive and discuss reports from board committees, Budget and Finance Committee, and Strategic and Planning Committee. So, we will take that up next month. No action was needed anyway. Agenda item 4, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the current strategic plan and related measures or dashboards. B, an assessment of systems and processes and prioritizations of activities and initiatives. And C, personnel matters. Mr. Giesland.
Yes. Members, in your packet is what I call your finalized dashboard. And and you've seen different dashboards that we've been putting together. One, the financial dashboard that shows some historical trends. This is driving towards showing you the basic inputs and outputs of the organization. So independent of any strategic initiatives that we may undertake, these are just basic metrics that any health-related organization like us, like a health district, would need to be looking at least on a quarterly basis, and that's what these are. And so you see it lists primary care patients and care encounters, urgent care encounters, and patient counts as well as dental. And again, there's not a whole lot of discussion around this. I just wanted to draw your attention to this, that you'll be seeing this on a regular basis, but it gives you an idea about the flow of people that we're serving. The next thing that I'll point out is, the dashboards that you've seen that we'll continue to pull together for you are described on the left, the other basic inputs and outputs. But as we work towards finalizing our strategic work plan, which we anticipate bringing back to committee in June for full adoption by the board the same month, next month, how do we report on the strategies? Now, we'll be discussing at the next strategic planning committee the types of measures that we'll be looking at for each strategy. Some are qualitative, some are quantitative. But the strategy updates will be different from the dashboard. So don't think that the dashboards that you just looked at will tell you whether or not a specific strategy is working. Again, those are just basic inputs and outputs of the organization. The strategy updates will tell you whether or not a particular strategy that we have pursued is actually helping us achieve an objective. So that discussion is going to be coming up in June, and I just wanted to point that out for your consideration. This is an informational item. I'm not asking for any action.
Any questions for Again, this is an informational item. No action is necessary. All right, we're at agenda item 8. Confirm the next regular board meeting date, time, and location. That's me. The next Central Health Board of Managers meeting is scheduled for June 27, 2018 at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas, 7802. With that, I entertain a motion to adjourn.
So
All right. All in favor?
Whoa.
All in favor, say aye.
Hi.
Against it, no. Thank you.
Whoa.
Thank you, members.